Hello and welcome to an interview with Dr. Kevin Katz today that is being hosted by Dentalcorp. I am Julian Perez, the Senior Vice President of Risk Management and Compliance, and I'm very happy to be with you today and very excited to speak with our guest, Dr. Kevin Katz.
Hi there, I'm Kevin Katz. I'm an infectious diseases physician and medical microbiologist. I run a large hospital infection prevention and control program and one of the largest hospital microbiology labs in the province. And I'm also the Chief Medical Officer of Practice Health Check, which is a small consulting company that primarily assists medical and dental clinics to comply with best practices to get ready for public health audits. And we work closely with Julian and his team and have a long relationship there.
Thank you again, Dr. Katz, for being with us. We've spoken in this format 2 times previously. The first time was way at the beginning of the pandemic in spring of 2020. And there were a lot of questions circulating. There was a lot of anxiety and concern. And here we are about a year later, and there's still questions circulating, and there's still anxiety and concern, but many things have changed. And some of those questions have been answered. And the questions I think that people are dealing with today are somewhat different. So I'd like to talk about 2 themes primarily. One is vaccines and vaccination, and the other are COVID-19 variants and variants of concern. So I know you're extremely busy and you wear a lot of hats, and we find ourselves in the middle or near the peak, hopefully, of the 3rd wave of this pandemic. When we first talked, you introduced me to the concept of waves of pandemics, and you frightened me with with a warning that there could be a 2nd wave. I don't know that you mentioned a 3rd wave, but here we are. And I just thought I'd jump into some of the hot pressing issues of today. The first one I'd like to talk about is COVID-19 vaccines. So a year ago, I'm not sure how confident people were that there would be a whole host of different effective vaccines available at this point in the game, but scientists have been working hard. People in your profession have been working very, very hard over the past 13, 14 months. So my first question is, it relates to some of the vaccine anxiety and hesitancy that's out there. And I thought maybe you could talk about risk. I'm a risk manager, so this is near and dear to my heart. So there's 2 different risks that I'd like you to address and compare if you could. The first is, what are the risks of the vaccines? We've been hearing some frightening stories from around the world, even a couple cases in Canada involving blood clots, involving 2 different vaccines that are on the market currently. The second risk is that people don't get vaccinated, that a large portion of the population remains susceptible to this disease. Can you just talk a little bit about how you view those 2 risks, how they relate to each other, and how you would compare them?
Sure. Maybe just to give context, it's important to sort of say where we are currently in terms of the 3rd wave, because that's part of the risk calculus that we're talking about. Right now, we are still on the upswing of the 3rd wave. There's about 4,500 new cases each and every single day in Ontario, and it seems to be gaining at about 20% every single week. The government has announced additional control measures, and people in my position are not super enthusiastic at the control measures that they've chosen to add. You'll recall that we've been in a lockdown and stay-at-home order for more than 2 weeks now, and yet the numbers continue to rise, and we can talk about that when we talk about the variants of concern. But the additional measures that they've chosen to add in really are disconnected, unfortunately, from where the problems have been occurring, based on information from the science table and from public health authorities. The problems have been centering in the manufacturing center, in abattoirs, in high-risk workplaces. That's not all workplaces, and probably retail to a much lower extent. And yet, in construction is also another hot spot. And then also in very specific geographic locales where frontline providers live in high-density housing. And yet the measures that they decided to implement really were a little bit more generic, getting rid of tennis and golf and kids outdoor playgrounds, where there really hasn't been any issue whatsoever. There's a few things that they've announced that will help somewhat, but not really target these major issues. So there's a lot of concern actually that will continue to swing upwards until they implement more effective measures. So all of that to say, we're in a really critical spot right now. There's 700 ICU patients, and we're pretty much nearing capacity, if not over capacity, in the intensive care units. There are quite a fair number of ventilators that were purchased at the beginning, but there aren't ICU nurses to actually staff all of these ventilators, and the physical beds are also somewhat of a challenge. So what they do is they ramp down all the elective surgeries. Elective could be a cardiac bypass surgery that you may not die in the next 30 days, but it will have long-term complications of ramping these things down. So that's where we're at. The vaccines are a miracle, really. They've come along super duper quickly because a lot of legwork had been done over the previous decade to be able to produce vaccines with some of these new technologies very, very quickly. The two main categories of vaccines that are on the market these days, and there's a couple of others around the world that are a bit more conventional in the way that they're manufactured, similar to past influenza vaccines. But the two main categories, these mRNA vaccines, which Pfizer and Moderna vaccines fit into, and then there's these adenovirus vector vaccines, which the AstraZeneca, which is a chimpanzee adenovirus vector vaccine, and Janssen & Janssen, a human adenovirus vector vaccine, fit in there. So these vaccines are extremely effective. They range, people always want to know what's the vaccine efficacy. And the answer is it depends on the vaccine. It also depends on the strain of COVID, because these variants of concern are all different. And there's three main variants of concern. But if I'm generalizing, the mRNA vaccines are somewhere in the mid-90s plus, a little bit lower for the variants of concern. And then the AstraZeneca is probably closer to the 70% range, Janssen maybe a little bit higher. But, and again, both of those would be a little bit lower for the variants of concern. But all of those studies are against any infection whatsoever, meaning that, will you become lab test positive with any symptoms whatsoever? Those numbers I just quoted are what that targets. The piece that we really care about is it going to make you sick enough to require hospital admission, to require being placed on a ventilator or dying from COVID? And all of the vaccines are extremely effective against all of those more severe end of the spectrum. So getting caught up in the numbers and the efficacy, I would say, is less of a concern. In terms of the side effects of the vaccines, they are extremely rare. The mRNA vaccines, there's been reports of anaphylaxis, like true anaphylaxis reactions requiring epinephrine to be administered. And that's somewhere in the order of 1 in a million, and it's fully treatable. And that's why people have to hang around the vaccine clinics for 15 to 30 minutes afterwards to monitor for that. And those tend to happen in people who have had anaphylactic reactions to other medications or other allergens in the past. They don't tend to just happen randomly. Again, they're treatable, and they don't have long-term consequences as long as they're treated properly. The two other, those adenovirus vector vaccines, are the ones that people have really been focused on. The AstraZeneca vaccine has this risk of blood clots, probably on the order of 1 in 200,000, somewhere in that ballpark. And the Janssen vaccine recently has had reports that somewhere in 1 in a million range. And the interesting part is it tends to affect younger people more, and young women in particular. So for Janssen, there was, I think, 6 or 7 reports, and they all ranged between 18 and 48, and they were all women, just in that Janssen initial reports, which is why the government has restricted the AstraZeneca to initially under 55. They just announced yesterday that they're going to drop it down to not under 55, over 55. And yesterday they expanded it to 40 and up. The reason they haven't been talking about age restrictions for Janssen is because we haven't actually received any doses of Janssen, despite it actually being approved in Canada, and it's only going to arrive towards the end of the month. So I would imagine that they will make some of those guidance decisions in the very near future. So, you know, those numbers can be paralyzing. And I manage risk all day long as well. And people want to get to the point of not having risk, but that's not the choice in this case. The choice is the risk of a natural COVID infection and all the consequences that entails versus the small risk, extremely small risk of the vaccines. And so at the older end of the spectrum, 80-year-olds have like a 20% mortality when they get infected with COVID. Someone at my age, middle age, maybe in the 0.5 to 1% range. You're not supposed to smile when I say middle age. And then younger people, a much lower rate of complications. But the variants of concern are shifting the spectrum down to the younger end and are causing more severe infections in younger people and pregnant women and those types of things. So you can't escape without any risk, and you need to take that 1 in 200, 250,000 and the 1 in a million in the context of just getting up and walking outside, crossing the street, doing anything entails risk. And I know it feels like an active decision to put a needle in and causing risk, but we all live out in society and are interacting, and the risk of COVID is very, very high right now. And the only way we're going to get back to normal is with the help of these vaccines. So
yeah, I think that's great. I think the context you suggested would be something that really helps and is often lacking from these conversations. So you hear, you know, there's 1 in 600,000 or 1 in a million or 200,000, and it's hard to think about that risk. All you know is, you know, vaccine and then blood clots, and I think start to form potentially irrational, well, perhaps they're rational thoughts or fears, but yeah, they're out of context. So, you know, 1 in how many times you go driving are you likely to get into a car accident? It's probably significantly more risky than getting the AstraZeneca vaccine, but nobody thinks twice before they jump into a car and, you know, drive to the store.
And then in terms of, you know, other risk, I mean, the getting hit by a car may seem out there, but it's in that order of magnitude. Young women taking the birth control pill, the risk of a blood clot is somewhere on the order of 0.1 to 1%, so that order of magnitude. So way, way, way higher risk with the birth control pill. Smoking dramatically increases that. And then just in terms of blood clots itself, I've talked about the risk of getting COVID. When people get COVID, they have a dramatically high risk of blood clots. So COVID actually causes thrombosis, and the risk of stroke after a severe COVID infection is very, very high. You know, my wife is a nephrologist, so putting patients with active COVID on dialysis, they end up clotting the circuit. The whole body is very, very activated in terms of the clotting cascade. So, you know, the paradox is the vaccine raises clotting a little bit, but natural infection raises clotting risk dramatically. So I think those are all the pieces that play into it. People are, you know, naturally hesitant. The common things we hear about are, I want to wait, it was developed too quickly, I want to watch, and all of these things are understandable, but you need to understand also that, you know, hundreds and hundreds of millions of doses have been administered to date. You know, probably we're pushing up on over 500 million doses in the world. And if there was a signal to be seen in terms of major complications or common phenomena, we would have seen it. I'm not discounting, there are lots of valid concerns that people have. I would suggest they put their hand up and ask their questions to their satisfaction and then proceed. We've had lots of conversations with people from different backgrounds, different ethnic origins, different geographic regions of the globe. And there's reasons for them to be fearful of the medical system historically, based on systemic racism, things, and those are all bona fide issues. But there's also very significant risk around COVID, and so there are some very, very well done informational videos from within some of these communities, and whatever community you're from, if you're from Eastern Europe or Russia, or if you're from the Black community or from Indigenous communities, there are leaders in all of these areas that have done some fantastic informational videos. You don't need to listen to me or Julian. You can get the information you need, and putting yourself more at risk based on things that have happened in the past, in my mind, almost compounds the negative impact that some of these systemic issues in history are doing, because they're causing harm in the present as well.
So I don't know if it'd be fair to say, based on what you've just described, but the risk of not getting vaccinated for anyone at this point, any age group, is probably higher than the risk of getting vaccinated. And that's not talking about the potential for you to then get it and spread it to someone else who's in a higher risk. But even for people who are, in their 30s, 40s, 20s, the variants, and I think it might be a nice segue to start to talk about the variants here, are affecting different age groups now. And, there has been talk, at least with regards to the variant that originated in the UK, that it's not only more contagious, but potentially more virulent, and that it causes more severe outcomes in a higher percentage of the population. Could you talk, there's two things. Before we close out the vaccine conversation, one thing that I'd like to bring up and hear your insights on is that speed when developing vaccines is very relevant. So if you're trying to develop a vaccine for a very rare disease, or a disease that only 1 in 10,000 people get, or 1 in 100,000 people might get, it takes a lot longer for you to know how effective that vaccine is, compared to when you have such high infection rates across the globe, where you can actually develop and refine the vaccines a lot quicker in that environment. Is that true? And maybe you can just say it in words that make more sense.
Yeah, no, I think that is true. So I would break down the big, it probably takes 5 to 10 years typically to bring a vaccine to market. And part of that is the development of the vaccine, and part of that is the testing of the vaccine. So you're talking about the testing of vaccine. Let's just park it for half a second. The development of the technology on the vaccine, these are new vaccines that allow manufacturing to go more quickly, but the technology of mRNA vaccination and the technology of adenovirus vector, that research has been going on for 10 or 15 years. So that wasn't just pulled out of a hat and let's try this. All of the legwork on that had been done ahead of time, so that all of the knowledge required, the manufacturing, the safety issues, all of that was completely ironed out and was ready to go for an eventuality like this. And so that chunk of work, it's not that we went too quickly. That was all done very, very correctly over a prolonged period of time. In terms of getting approvals for a vaccine like this, you're right. So if we're trying, for example, to do a meningococcal B vaccine for all of us who have kids who are going into university dorms or high density areas where it would be indicated, to prove that new meninge B vaccine works, you need enough of the outcomes to happen. And if you only have 50 cases a year, then you need to go to countries around the world, get ethics, get the infrastructure set up, and then continue to recruit for years and years and years until you hit the target, so that you can say in the placebo group there were this many cases, and in the treatment group there were this many cases, and statistically we've proven that it works. And you also need to have enough cases to make sure that you don't have signals of that it's unsafe in some way. So COVID set it up so that all of those things could dramatically go more quickly, because there was so many cases that you can get the required outcomes much more quickly, firstly. And there were multiple companies that were doing it at the same time in multiple different jurisdictions around the globe. Each of the phase 3 trials was somewhere on the order of 40,000 people, and they were able to each study to reach statistical significance where the number of COVID lab confirmed cases in the placebo were significantly higher than those in the active treatment group within a few months. And in those 40,000 trials, just to emphasize, because I don't know who's listening to it, but I would imagine it's sort of a slice of the world and a slice of our country, they were very deliberate to require, the FDA, at least for Moderna and Pfizer, to require that the breakdown of those 40,000 people matched the US population perfectly. So that means that there was an appropriate number of Latina and Latinos and an appropriate number to match the population dynamics of African Americans and people over 65 and people under 65 and people with chronic conditions and people without chronic conditions, like the whole gamut. Mm-hmm. And you can actually Google it and say Pfizer study, phase 3 study, recruitment criteria. And I've actually sent these around because I have nurses who come up to me and say, like, how do I know that my mRNA is not different than a white person's mRNA? And I'm nervous about this. They know me, so they'll stop me in the corner and just ask me this. And I think they're fantastic questions to stop and ask that. And I point to the studies, and I also point to the fact that our cells have mRNA. We make it for ourselves on a daily basis to produce every protein we need to survive. Mm-hmm. It's just a brilliant way of using the cellular machinery to produce that little protein to activate the immune system. Mm-hmm. So, to say it's rushed, I think is a stretch. These studies were done as rigorously as any other, but it was just set up to be able to, all the technology was ready and the studies were able to happen more quickly just because there was so much COVID around.
Mm-hmm. Yeah, and I think also there may not be an analog for how focused the scientific community across the world was on one single accomplishment. And so I think that also just demonstrated what we are capable of when we put all of the resources of the major governments and institutions and hospitals across the world.
And just to put a name to that, so Operation Warp Speed, as they called it, but each the European agencies and the Americans. The other thing that tends to happen with vaccines is they go through the trial and then they see whether it works. Nobody's going to put any money at risk. But with all of these billions of dollars that the American administration, the Europeans put behind it, essentially they said, we think these are going to work. Let's do the studies. You guys do the studies. You guys start to manufacture it as quickly as you can. And if the studies don't work, we're going to throw tens of billions of dollars in the garbage. And they took that risk. They put it at risk to save time, which is not the normal process. But you're right, the whole world essentially was trying to keep time short. And if the studies didn't work out, it would have gone in the garbage. That was just an accepted risk. They would not put the population at risk.
And there were other companies, pharmaceutical companies, whose attempts at a vaccine didn't work, and that's exactly what happened in those cases. So let's talk about variants for a little bit. First off, what is a variant? People I don't know that this was in anyone's vocabulary outside of vaccinologists, maybe virologists a year ago today. But now everybody's talking about variants of concern, and sometimes you hear the word strain and mutation, and all of these are all sort of related concepts. 1 second here, I'm getting a call. Today, I don't know if for those watching, Rogers is not working, and so people are contacting me on apps that I didn't know you could make a phone call on. so I apologize for that. Maybe you could just talk quickly about variants of concern. And how did we get here, essentially? Because it seems like for the longest time, everybody said that COVID-19 or coronaviruses in general are not as quick to mutate as influenza viruses. And then I woke up one day and variants of concern had taken over the globe.
Yeah, well, so variants and strains, I think you can probably use those terms interchangeably. Variant is the correct term in viruses as long as you're in the same type of virus. As it gradually mutates, we would call it a variant. And a variant of concern, as opposed to a variant of interest, most people would say that there are 2 or 3 things you would need to meet at least one of several criteria to call it a variant of concern. A variant of concern can be more transmissible, more communicable. It can cause more severe disease. It can be more virulent. Those are synonyms that I'm saying for each of those 2. And then the last one is that it can have the affinity to escape immunity, meaning a natural COVID infection you'll be protected from, typically from the same strain, or a vaccine. So those would be 2 ways to get immunity, the vaccine or natural infection, and some of these variants of concern can escape that immunity, potentially, at least there's a concern about it. So there are 3 main variants of concern that people are talking about now. There may be more that get added to the list. These are the 3 in Canada. Other countries have maybe added 1 or 2 to their lists based on those same 3 criteria. And the nomenclature is a little bit confusing. Some people like naming it by the country of origin. So we'll casually say the UK variant, the South African variant, the Brazilian variant, and then others name it based on the actual official strain lineage. So the UK would be the B117 strain. There's a bunch of periods in there. The Brazilian would be the P1 strain, and then the South African strain would be the B1351 strain. And we can talk a little bit about the difference of strains, but why are they evolving? The SARS-CoV-2 virus, the official name of this COVID-19, the virus that causes COVID-19, is an RNA virus. RNA viruses naturally mutate as they replicate their genetic material. So that's what viruses are made to do. There's a philosophical conversation, are they alive or not they alive? Because they don't actually have their own cellular machinery. They use a host cell to actually replicate their RNA, but that's their goal in life, is to replicate their genetic material. And as the RNA is replicated, it naturally makes little mistakes. So it may, A, T, C, G, all those base pairs, it'll accidentally replace one just randomly by accident. And it doesn't really have a correcting function. So in my own cells, if I'm making a new lining to my colon, for example, if it makes a mistake, my body surveils for that, because if it doesn't deal with it, I could end up with colon cancer. So it watches for these mistakes, and if it's a big problem, it'll kill the cell and make it go away. Whereas these viral strains just make mistakes and they accumulate them. And the ones that are problems, those viral strains sort of die off and don't replicate. And the ones that give it a benefit very quickly amplify up. And so the strains that are more transmissible very quickly through Darwin's theories will replace the less fit strains. Was this predictable? I think this was predictable. Why are they coming about so quickly compared to influenza? Well, I'll just describe in terms of lab positivity, because we probably don't capture all of the influenza, but in a normal season, my lab would, let's say, confirm, or at least for my hospital, would confirm 150 flu lab test positive cases a year. And we only test inpatients, but 150 a year, a season. How many did I have yesterday at North York General? I had 160 lab confirmed SARS-CoV-2 flu, SARS-CoV-2 COVID cases just at my hospital. So we have 4,500 lab positives a day in Ontario, and an entire flu season we may have, I don't know, let's say 1,500 or 2,000. So that's the issue right there. We need to get the burden of this disease down. The more COVID is circulating, the more it's going to keep replicating like crazy, the more it'll randomly stumble onto a mutation that it likes better and then replace the old strain. Once we get it all under control and there's not a lot of COVID circulating, then the mutations will also gradually settle down.
there's another good reason to get vaccinated.
Yes, exactly.
Because think about it, we're all sort of natural petri dishes for the COVID virus to try to find a mutation and become more virulent, not intentionally, but that's what we are. Um, I've heard that, or there's a theory that persons who are immunocompromised can potentially allow the COVID virus to linger a little bit longer than the usual, whatever it is, 10 days or 2 weeks that we talk about. And that that potentially creates an environment where these mutations are more likely. And I think I heard or read that the Brazil variant, for example, was likely to have evolved in that environment. Can you explain what that conversation is? Whether or not it's been proven, I'm not sure that's possible to know, but can you explain how the thinking goes?
Yeah, I mean, I think it's just natural selection, really. The more virus you have at a macro level, at the societal level, or the more virus that you have within an individual, again, the more that it's exposed to your immune system or to some antibodies from past infections or from some antibodies from immunization, the more it's they're smart. They're not just going to sit around and say, okay, kill me. They'll if you have a population of 1 billion viral particles in your nose and pharynx, and 1 or 2 of them have had mutations that give it a benefit against the little bit of immunity you have from the vaccine or whatever, then it'll kill 99.9% of them. And that 0.1% can just grow up and replace. And so I guess if the virus is hanging around in an individual, then it could potentially do it within an individual, but it's probably more at the society level where you have 5,000, 10,000, 100,000 cases a day in a country, and it's just sort of to be expected. But I think maybe I'll bring us back to the big picture of what we're trying to accomplish. And this brings us, I smiled when you said that, I talked about a second wave. I think we did talk about multiple waves, and I did say that subsequent waves can be more severe. And at the time, I think you're going to pull out the video and prove me wrong, but
no, you're probably right.
I don't know if it was that video or other videos, but why are the subsequent waves more severe? It's probably 2 different factors in how they interact, or what proportion emphasis. One of them is that society gets pooped out and doesn't actually follow the public health measures anymore, which we see playing out, right? Like everyone's craving for interaction, affection. That's just what we're built as humans to do. And then the second thing is that the strain can gradually mutate and become more virulent. So which piece is which, we'll see. But ultimately, if we go just up to 30,000 feet, this virus was a bat coronavirus, not a human coronavirus. It was a bat coronavirus. And viruses are species specific. So when I have a cold, I can give it to Julian, but I can't give it to my dog. And when my dog has a virus, they can give it to another dog, but they can't give it to me because it's species specific. So they have their cold viruses, I have my cold viruses. Bats have their coronavirus, humans have our coronavirus. Every so often it can jump species. And when it does that, and it's able to transmit effectively, that's when you get a pandemic, because it's not really made for me, and I have no immunity against that strain. I've never seen it, and all of the billions of humans have never seen it. So it can cause much more severe disease. The goal is to actually get everybody to have some immunity towards it, and then it's effectively become a new human virus. It won't be a bat coronavirus anymore. I have been vaccinated, so my system now is familiar with this strain. And so can I get infected by a new variant potentially? Yeah. Will it kill me? No. Because now those variants are all versions now of what my body thinks is a new human virus. It's not a bat virus for me anymore. So that's why immunization is so important, especially the first year. And the reason we get 2 is just like babies get 2 flu shots and every adult gets 1 flu shot. It's because babies don't have any immunity towards flu. So the first time you give 2, and then right now we're all babies for this COVID virus. get the basic immunity, and then really all of the severe outcomes should melt away, and then we can go back to normal. Does it mean that we won't be spreading COVID when we go to Starbucks? Yeah, we'll be spreading COVID when we go back to Starbucks, but we're not going to be killing each other. We're not going to end up in the ICU because it's become a humanized virus, if that makes sense. So, it'll turn into like the flu virus. Right now, this is like a pandemic influenza. And then next year, it'll become like seasonal flu. We need to get flu shot again. We need to get flu shot again just to deal with the evolution. But you and I are not nervous of dying of influenza. It's just like the very severely immunocompromised and elderly who are more at risk. And even then, it's like a couple of percent. It's not 20%.
Yeah, it certainly doesn't overwhelm the healthcare system the way we've been seeing COVID is able to do, not just once,
right,
but over and over again. If to your point, if people let their guards down, or as it mutates. Or have you heard, or are you seeing here in Toronto an greater impact on younger individuals? I think you mentioned it earlier. And if so, is that the case because of the virulence, or is it just because of the population in which it's circulating? Or again, is it a combination of two and we just don't know? Doesn't really matter. We just need to get vaccinated.
Well, at the end of the day, I don't think it matters. I think we need to get vaccinated. But there's no question that the UK strain, the B117, is now makes up 90% of all of the strains that are causing infections. It's gone from 0 to 90%. So there's less of the original strain back from Wuhan than B117 now. In the past month, we went from 0 to almost 100. And we know that it's more virulent, that it causes severe infections and deaths close to 100% higher. Now, 100%, that's relative. In my age category, if I said that it's like a 0.5, so it goes from 0.5 fatality rate to 1, which doesn't sound dramatic. For an elderly person, it might go from 15 to 30, which is bigger. So there's definitely an increase in the severity at the individual case level, but the bigger thing is it also transmits much more effectively. So instead of transmitting, one person transmits with all the measures we currently have in society to, let's say, 1.2 people or 1.3 people, used to be 2.5 people before we put all the public health measures in place. The UK strain increases that by about 0.4 or 0.5. So one person will transmit to 1.7 people, 1.8 people. And so the old measures over Christmas, when we locked down, we were running with a communicability factor of one person gives it to about 1.3 people, and the lockdown brought it to 0.9. And as long as you're below 1, it'll bring your case numbers down. These new variants with this additional benefit means that if we're sitting at 1.5, the same lockdown measures may leave us at 1.1, meaning that we're still in exponential growth unless we put more measures in place. And so we're clearly seeing more young people in the ICU. The myth, even in the first wave, everybody thought there was 80-year-olds in the ICU. The 80-year-olds were dying in the long-term care facilities. They weren't actually coming to the hospital. There were 60-year-olds and 50-year-olds filling up all the ICUs. Now there's some ICUs have some 40-year-olds, 30-year-olds, still a lot of 50 and 60-year-olds. Is it because there's just more infections overall? Probably yes. Is it because we've vaccinated all of the 80-year-olds and 70-year-olds? I don't think we've done all of them, but that's taken a big bite. So those people are protected and they're not showing up anymore. So it's hard to tease it all out. The variants clearly are causing more infections in pregnant women. There was a report on the news last night from Mount Sinai that 20% of their ICU patients are pregnant women now. It's changing, there's no question. And we have an opportunity to vaccinate. It's just too bad that the government procurement strategy was a total belly flop.
Well, I mean, yes, I think Canadians are feeling a little envy of some other countries that are vaccinating a little bit quicker and that are relaxing public health measures. And so, yeah, don't want to get into the politics, but I think, it's a good sign that we wish it was going faster, and hopefully that'll mean there's strong demand for people to get vaccinated as there are spots opening up. And I'd like to, underscore your point that many of the, octogenarians are not showing up anymore. And I think that is one of the first real success stories of the vaccine campaign, and it's easy to overlook, but the counterfactual death rate would probably be a lot higher had that not been the case. And so we have dodged a bullet, even though maybe it's not in the media as much as it could be, because of all of the sort of grass is greener mentality, which I'd certainly fall under. So that was very helpful on vaccines and variants. I think I've already taken up more than the amount of time you had allotted. I just wanted to, if you would entertain me this, discuss some of the infection prevention and control measures in dentistry that provinces across Canada to different extents have implemented, and which of those you think are more likely responsible for the success of dentistry and preventing spread from patients to providers. And then maybe touch on just some of the behavioral recommendations you have, having worked with a lot of dental offices and seen, spread within dental offices that is inevitable, the kind you see whenever people congregate. But what should dental office workers, clinical and non-clinical, continue to do? What's been working, and what are some of the maybe surprising things that haven't made as large an impact as we thought they might a year ago?
Yeah, I think the dental community has done a great job adapting to these really rapidly evolving, confusing circumstances, and unfortunately, it's hard to know what the correct answer is. We'll never know it because you can't do a study in the middle of the risk. And so there's a lot of erring on the side of caution. And perhaps once people are vaccinated, some of these simulation studies can be done to actually figure it out. But I think, in terms of the PPE that's being used and a focus on the aerosol generating dental procedures, I think that makes a lot of sense. Going into COVID, there wasn't much fuss about it, but if you actually look at some of those old studies from the 70s and 80s, there probably was transmission of bacteria and viruses that was happening. It was just, you're probably a young dentist starting out and you get some mild things and you're good and you never notice it again. So I think the practices there probably will end up being sustained. We can probably let our guard down in terms of how rigorous and the need for N95s once people are vaccinated, perhaps. But until people are vaccinated, those small aerosols probably still are enough of a concern. The cleaning of the environment is definitely an issue. The CDC is de-emphasizing it, but again, that's probably not going to a grocery store and touching the same package of peanut butter is probably not the same thing as a dental office where you have, high pressure water and droplets that are being generated. So cleaning of the environment between cases, so that the dental oral healthcare providers are not self-contaminating. I think the piece that's been underestimated by some, and it's true across society, not just dental clinics, is that there's a fear of other. And people are afraid of the patients, which is, it's good. It's, I think a lot of the changes that have happened on the PPE side and the cleaning side and the gloving and, the protocols in terms of how the rooms are turned over and all the rest of it. But, probably the vast majority of problems that have happened in clinics have actually been in the lunchroom, at the receptionist desk, outside of work, after work, the carpooling. And that's true in dental clinics. It's true everywhere, actually, that people are fearful of other, but actually the biggest risk is the person that you know well and that you feel safe with, because COVID is transmitting it in the community, and it's able to transmit when you're asymptomatic. So relying on just knowing someone, if they're not in your immediate household, is probably the biggest risk for everyone.
Has asymptomatic transmission gone up with the new variants in your estimation?
So Probably yes. Nobody really knows exactly why they're more transmissible. There's been some work looking at whether the viral load is higher, and it doesn't seem to be the initial indication, at least for the UK variant B117, that doesn't seem to be the issue. Some of it looks at the length of shedding, and maybe it sheds for a little bit longer. It looked like the old wild type, I'll call it wild type, that's not the correct term, shed for about 7 or 8 days. And there's some very small studies that suggest that the UK variant can shed out to 13 days. So that will account for more transmission. And then it's possible that the average doesn't transmit more, but you have these super spreader or super shedder events. And if these variants are more likely to do that more often, like instead of 1 in 100, you have 3 in 100, and that super spreader goes to 40 people or 60 people, it happens just a little bit more, that really amplifies up very, very quickly, especially with logarithmic growth, because it puts you a little higher and then double, double, double. You end up, much, much higher very quickly.
Thanks, that's helpful. I'll give you a lot of credit. The first time we talked, you said that if COVID were to spread in any workplace, it would probably be from friends gathering in a staff room or a lunchroom. And, there haven't been, to my knowledge, any official reports of patient to provider, provider to patient COVID-19, but just like, people living together, working together in whatever environment, that has been a bigger challenge. And you also said that, for doctors who work in PPE and are constantly practicing hand hygiene and physical distancing at home, at work, going home could be a higher risk situation because you live with 3, 4, 5 other people. And obviously you're going to let your guard down. And to the extent COVID has been introduced into offices, it's come from those avenues as opposed to patients. So good news is we know it works. If the whole world just acted like a dental clinical team providing patient care, we would kick this virus much quicker. But that's not fun either. I don't know how much PPE you have to put on a day-to-day basis, but that can be pretty onerous, expensive, and just, I think, emotionally exhausting to put it on and take it off, put it on, take it off. So I want to thank you for your time. Is there anything any message you have for the dental community that we haven't addressed as sort of a parting message?
Yeah, well, I would just try to convey a message of hope. We are getting closer, and the dental community has taken a leadership role in managing this. I know that many have tried to put their hand up to take an even bigger leadership role in terms of vaccine administration and testing sites and things like that. So I think continue to push and advocate for the dental community's role in this whole big puzzle. And the other thing I would say is don't underestimate the power of influence of leaders within your groups, especially around vaccination. I really do think we should try to get everyone vaccinated. And some dentists feel badly, some doctors feel badly trying to talk it up. They feel everyone should make their own decision. But there's good studies that show that if a leader within a team advocates for something, speaks about it passionately, that it does get the rest of the team on board, firstly. And secondly, have conversations, find out what the problem is if somebody doesn't get vaccinated. Sometimes they just want to have a specific question answered. They're too shy to ask it. They don't know where to get the information. And really having a full clinic, or ideally like a full big hospital of 4,000 or 5,000 people vaccinated, it really does work. When we started vaccinating in long-term care, those big outbreaks just melted away. There's more outbreaks happening in hospital wards now than in long-term care, and that's just because the patients coming in aren't vaccinated. And in long-term care, there's not an issue right now. I do think the dental community has been at the forefront and can continue to be that, both within your individual clinics and also at the big system level. So a big congratulations. I think hopefully by the end of summer, we'll be back to normal. I was hoping it was going to be a lot sooner than that, but procurement seems to be falling apart.
Yeah, yeah. Well, so with people getting outdoors, people getting vaccinated, and people staying strong mentally and emotionally, not letting their guards down just yet. I'm confident too. In a few months, we'll be in a much better place. And Dr. Katz, hopefully we can talk about something other than COVID.
Yeah, we'll get back to reprocessing and sterilization.
Yeah, also very, very important. And your help on those fronts have been totally invaluable. So thank you again on behalf of myself, on behalf of Demacorp, on behalf of our community. We really appreciate your time, and thank you for the work you're doing at your hospitals with your patients, and spreading the good word.
Okay, thank you. Stay well. Nice to see you.
Take care.